This brief report by Fraterna Sperling et al. Explores the delayed detection of vertical HIV-1 transmission linked to maternal use of long-acting injectable cabotegravir and rilpivirine. The study highlights the implications for HIV in pregnancy, focusing on long-acting antiretroviral therapy and perinatal transmission.
Effective maternal antiretroviral therapy during pregnancy is crucial for preventing perinatal human immunodeficiency virus transmission, achieving near-zero transmission rates. Thoughtful. European guidelines recommend postnatal testing of human immunodeficiency virus-exposed infants. Long-acting injectable antiretroviral therapy, like cabotegravir plus rilpivirine, is approved for virologically suppressed adults, but not recommended during pregnancy with detectable viral loads. A 22-year-old pregnant woman with HIV-1 subtype F was referred during her third pregnancy. Concerned, she was non-adherent to her prescribed oral antiretroviral therapy, which included dolutegravir and emtricitabine/tenofovir disoproxil. This non-adherence led to dangerously high viremia levels. During the second trimester, the patient was admitted with esophageal candidiasis and herpes zoster, showing a peak viral load of 603,000 copies per milliliter and a CD4 count of 210 per milliliter. Concerned, at 28 plus 5 weeks, off-label long-acting cabotegravir/rilpivirine was initiated, leading to a significant viral load reduction to 89 copies per milliliter by delivery, demonstrating the regimen's efficacy. During the second trimester, the maternal peak viral load was 603,000 copies per milliliter, with a CD4 count of 210 cells per milliliter, indicating significant immunosuppression. Relieved. At delivery, the viral load dropped to 89 copies per milliliter, a greater than 99.9% reduction. Postpartum, viral suppression was maintained at less than 50 copies per milliliter. Thoughtful cytomegalovirus reactivation was not assessed, despite seropositive status. The infant, born at 38 plus 1 weeks, was clinically well and exclusively formula-fed, avoiding postnatal human immunodeficiency virus transmission. Concerned, initial human immunodeficiency virus tests were negative until day 131, when both proviral deoxyribonucleic acid and ribonucleic acid were positive. Postnatal zidovudin prophylaxis was halted early, and congenital cytomegalovirus infection was treated with valganciclovir, though not continued post-discharge. On day 131, HIV diagnosis was confirmed after previous negative tests. Concerned, by day 140, viral load exceeded 10 million copies per milliliter. Immediate treatment included zidovudine, emtricitabine, and dolutegravir, with cotrimoxazole for prophylaxis. Relieved. The infant's viral load rapidly declined, reaching suppression by 14 months, with no resistance detected to non-nucleoside reverse transcriptase inhibitors or integrase inhibitors. Cabotegravir levels of 60 nanograms per milliliter were detected in the infant's plasma at 6 days old, indicating significant transplacental transfer. Curious, rilpivirine was undetectable. By day 144, no antiretrovirals were found. Thoughtful. The rapid decline in cabotegravir levels post-birth suggests initial high exposure, potentially suppressing the viral reservoir and causing false negative results for months. Transplacental transfer of long-acting cabotegravir suppressed the infant's viral reservoir, leading to false negative HIV tests. Curious, the transmission likely occurred in utero before long-acting cabotegravir/rilpivirine initiation when maternal viremia peaked. This suppression extended beyond the standard European testing window of 90 days, illustrating a pharmacologically induced delay in HIV detection. The infant was exclusively formula-fed, eliminating postnatal human immunodeficiency virus transmission via breast milk. Calm. The mother maintained viral suppression with human immunodeficiency, virus 1 ribonucleic acid, 50 copies per milliliter postnatally. Viral rebound in the infant on day 131 is consistent with intrauterine acquisition. Thoughtful. Cabotegravir detected on day 6 confirms significant in utero exposure, suppressing viral replication postnatally. The mother was cytomegalovirus seropositive, but reactivation wasn't assessed during pregnancy, despite advanced immunosuppression. Concerned, cytomegalovirus reactivation can facilitate human immunodeficiency virus transmission through increased viral shedding and immune activation. The infant had congenital cytomegalovirus, confirmed by ultrasound, but treatment was incomplete. Size. Cytomegalovirus-driven immune activation likely increased the risk of in utero human immunodeficiency virus transmission. Delayed HIV detection in Los Angeles C.A.B. PrEP recipients is linked to viral suppression. Curious. In adults, CAB suppresses viral inoculum, while in infants, transplacental CAB suppresses the viral reservoir. Detection delays extend beyond 82 days, with viral loads exceeding 10 million copies per milliliter by day 140. Thoughtful. No resistance was detected in this infant case.
Current European AIDS Clinical Society Guidelines 13.0 consider human immunodeficiency virus ruled out in non-breastfed infants if undetected by 3 months. However, this case shows that infants exposed in utero to long-acting cabotegravir/rilpivirine may still be infected. Extending testing throughout the first year is recommended for such cases. HIV molecular testing involves detecting HIV proviral DNA using polymerase chain reaction assays targeting the ENV and long terminal repeat regions, minimizing false negatives. HIV-1 ribonucleic acid levels are quantified with the COBAS assay. Pharmacokinetic analysis of antiretrovirals like cabotegravir and rilpivirine is conducted using liquid chromatography, tandem mass spectrometry, with a critical detection threshold of 25 nanograms per milliliter, highlighting delayed HIV detection risks. This clinical algorithm suggests extending molecular testing beyond the standard 3-month window for infants exposed to long-acting cabotegravir in utero. Measuring infant plasma cabotegravir concentrations at birth can help assess the risk of delayed viral detection and guide the intensity of follow-up surveillance. Off-label use of long-acting cabotegravir/rilpivirine in pregnancy is rising, especially among women already on therapy. This case shows a rapid viral load decline with long-acting cabotegravir/rilpivirine in late pregnancy, crucial for high viral load cases. However, urgent pharmacokinetic studies are needed, as cabotegravir and rilpivirine have different placental transfer profiles, affecting infant exposure and viral suppression. This case highlights a new diagnostic challenge in vertical HIV-1 transmission with maternal long-acting cabotegravir/rilpivirine therapy. Transplacental cabotegravir transfer can cause false negative nucleic acid testing results, necessitating extended testing beyond 3 months. Prompt antiretroviral therapy initiation is crucial for effective treatment. Updated guidelines and further research are urgently needed to address this emerging clinical scenario.